So welcome all of our people who have called in on behalf of Nina and myself. Thank you so much for calling in and being interested in what we have to share with you today. We'll be sharing what we know both from our own, 30 years of experience of doing community-engaged work and also from some really excellent research that we've done as well. And I just want to, before I begin, thank Sarah and David for a seamless setup to actually share with you our data today. So, welcome everyone again. This is Bonnie Duran. If you didn't hear me before, I was just, welcoming you on behalf of Nina Wallerstein and myself to this presentation, and had a huge shout out of gratitude to Sarah and David for a seamless, almost seamless setup. So I just wanted to give you my social location, mixed race person, first generation college student. I am a college professor because of a few things, because of the civil rights movement, because of the women's movement, and I was also a very early participant in the mindfulness movement. So all of three of those totally contribute to why I am sitting right here right now talking to you. And I just want to say one word or two about why social location is important. It's important because the whole notion that we cannot, and I'm going to use a very academic term here, universalize our subjectivity. We can't know what people in other social locations know is one of the fundamental reasons why we want to do community-engaged research, because other people have important answers and important questions that we need to engage with. So turning the baton over to my dear friend, Nina.
So just likewise, I also wanted to present a little bit, welcome everybody as well. So I came out of a Jewish immigrant ethical culture, and likewise, I think I went into academia as a way to maintain an activism role in academia, but an activism role in life through academia, with the opportunity then to turn to empowerment as a core frame for all that I have worked on, working with youth, alcohol prevention, working in Latin America as well as the U.S., but have spent many decades now working as a guest in many ways, but as a co-researcher in Indian country and with tribal research teams that are partners, and have learned a tremendous amount from them. And the last 10 years have been in this ongoing agenda of trying to understand how community-based research really works and its connection to community-engaged research and academic other implementation science. So we wanted to share our stages of development of how we have thought of this last 10-year process for us, Bonnie and myself, with other colleagues around the country, of CBPR, the development of a model that we've created, its relationship to implementation science, and then providing some of our data that shows how we've been evaluating and strengthening partnerships with the goal of strengthening them through understanding how we measure partnering practices and outcomes, and then end with our next steps of how we're working to keep this integration going and tightening the integration actually between CBPR and dissemination and implementation research. So just quick definitions. We know that community engagement is a larger definition of working collaboratively with people and groups and communities across many different identities, geographic locations. But CBPR more directly talks about engagement as a collaborative, partnered process rather than just any type of engagement, with the clear recognition that you start from the research topic of importance to the community. And here's where it becomes very tied to implementation science, because of the goal of combining knowledge and action for actual practice, policy, and program changes in communities, actual social change for improving community health to eliminate health disparities. So I think there's a direct tie in the intention of CBPR and implementation science and dissemination into practice. We have used this very easy kind of way of thinking. Often there's research that's done on communities. In many, we identify by zip code a set of communities or geographic locations. We do our research. Many of us do research in communities, in settings such as schools and homeless shelters, et cetera. And as you approach the with preposition, that's the capacity to think of how do you do research with community partners, and that's what we're trying to focus on in terms of CBPR. We see a lot of overlap in how you think about the frame of CBPR and D&I research. There is the context and environments. There is the organizational settings. And in our CBPR, I'll be showing you in a minute that we think of the organization as the partnership itself. And to move towards implementation and disseminating projects, you have to consider the organizations, consider who's the decision makers, who are the champions, how does this get adapted or implemented in that particular setting. It's the same thing for partnerships. How do you think about the context, the role that a specific health outcome might have in bringing the partnership together? Who are the decision makers in shaping the research design, and how is it implemented to fit the local culture, theories, knowledge base of that community or setting, and looking towards a range of outcomes which in fact overlap considerably with the implementation science of sustainability, capacity, and that the idea that these are shared kinds of innovations. And we can talk about this paralleling and mirroring in the later questions if you're interested. We wanted to present today 3 of our stages of our own CBPR national research. Stage 1 was the development of the conceptual model. Many of you might have seen it already. It's been published in a variety of places. We had NIMHD funding for a 3-year set of small pilot grants. Stage 2, we had NARCH funding, 3 major partners, University of Washington and New Mexico, plus our tribal partner, the National Congress of American Indians Policy Research Center, where we really work to validate our model, create measures and metrics, test them out, develop some psychometrics on these measures, look at the ways practice of CBPR is associated with outcomes. Again, many of those outcomes mirror implementation outcomes. And then stage 3 will end with this presentation with our new 5-year R01 from the National Institute of Nursing Research, looking at measures, define our measures, and then interventions that can help partnerships be more successful in reaching the outcomes that they most care about. So a little bit of stage 1, we had this initial funding. We did a large literature review of measurement tools and metrics. We created the model, validated our design with a think tank of academic and community research partners from around the country, very, very important to us. And we developed our own protocols for working collaboratively as 3 partners, as I mentioned before. Stage 2, we had a study led by our Native partner, the National Congress of American Indians Policy Research Center, through NARCH funding, which is an acronym for Native American Research Centers for Health. NIH funding, you can see the variety of institutes that funded us through this process over those 4 years. And we had 4 aims to assess the variability across the country of CBPR practices and outcomes, to assess the impact of governance and the difference between working in tribal communities, American Indian Alaska Native communities, and other communities of color or disenfranchised or other communities with social identity. And then we focused a lot on the development of measures and metrics of these partnering practices and outcomes so that we could assess associations among these processes and outcomes, and to begin to identify what we hope to share much more as we move forward. What are the promising practices within partnering that make a difference? What are the tools needed to strengthen partnering practices so that we can actually have better outcomes that we all care about? So we created, as many of you might have seen before, this CBPR conceptual model. It looks complicated, but if you just look at the 4 ovals, it shows that every research occurs in a context. That's true of D&I science as well, very focused on understanding different contexts, whether it's a political context, a social structural, the socioeconomic context of a community, whether it's the health issue chosen, community readiness. Every research then has, in a CBPR or community engaged framework, has the dynamics of working together. That's that second oval of partnering dynamics, whether you choose to have memorandums of agreement or choose to just have informal guidelines, whether you have certain ways of having decision-making or leadership development. It all occurs in a relationship process. If you are partnering, then it impacts the third oval of how you end up with your research design and your interventions. It should integrate the knowledge from the community, from the culture you're working with the academic knowledge that you're bringing. You should be able to create synergy together, and it will change then the research design because you'll be bringing multiple stakeholders together to actually decide who's the sample, what kind of final refinements you might be making on the methodologies. And then the outcomes will, in fact, be broader because they'll be the grant outcomes, of course, we hope, regardless of what institute funds you or what foundation funds you or whatever, what project you're doing, but there'll also be the growth of capacity of community partners to take on new research. There'll be the potential sustainability of interventions because the intervention will take place within that setting appropriately, again, very parallel to D&I interests. There'll be change of power relations between academics and community partners. So this model we have found to be useful and available to many partnerships as they've gone forward. And now I'm going to turn it back over to Bonnie to talk about some of the more specifics of our findings on validating this model.
Thank you, Nina. That was well done. So I want to talk to you about the stage 2 of our research, which is validating the model through a big survey that we have done. I'm trying to figure out how to, oh, there we go. So we started out in 2009 by downloading over 100,000 extramural-funded project abstracts from the NIH reporter. And from those over 100,000 abstracts, we did key term searches electronically and also hand-reviewed many of them and actually came up with a total of 294 projects that we thought fit the criteria of community-based participatory research. In addition to those 294 projects downloaded from the reporter, we oversampled in American Indian populations by including all of the projects that were funded under the Native American Research Centers for Health Initiative between the Indian Health Service and the NIH. And we also oversampled or included all of the community-engaged projects that were funded under the CDC Prevention Research Center Initiative. So we had NIH-funded projects, we had IHS and NIH-funded projects, and we had CDC-funded projects in our sample. Of the key informants of all of those 333 projects, 200 of the principal investigators of those projects responded to our first survey, almost 70% of them. And then we had, a two-stage survey process. Our first stage was contextual issues and, finding out who the partners were. And again, we had about 69% of all of our PIs responded to that survey. And then we had a second phase of surveys looking specifically at both community partners and academic partners with a series of questions about the core constructs of our model. And in that, we had about 310 people, or 77% of community partners responded to the survey, and about 70% of the PIs who we had contacted before responded to our survey. The key informant survey looked at project demographic features, decision-making, all the things you see here, research integrity. I think Nina covered that a little bit. And then our community engagement survey, which included, again, community partners and the PIs, included context, social and human capital, alignment with principles, governance mechanisms, it really included as many valid measures that we could find that described what our community partner and relational dynamics section of the model, really collected data on the workings of that process. And then as outcomes, we looked at partnership synergy, which is a proximal outcome, culture-centeredness, concrete and perceived outcomes, and personal, political, professional level outcomes in a proximal, distal, and ultimate outcomes from a bit of a time perspective, though it's all cross-sectional data, so we can't really say that much about time yet. This was the measure of partnership synergy. I'm sure many of you know of it. It's done by our wonderful colleagues out of Brand at UCLA. This is one of our proximal outcomes, and it asks the questions: by working together, how well were partners be able to understand and support the partnership, work together well, to develop strategies, recognize challenges and come up with good solutions, really look at the community as a whole and work together as a team. Just getting to some of what we found, so this is the big, wonderful stuff that we're in the process of publishing right now. Looking at the context variables, in the context, we're looking at the bigger picture, things like social, structural, socioeconomic status, place, the history of research in different communities, our deeper understanding of racism, cultural factors that might impact implementation, exactly the type of stuff that you're going to want to look at for implementations research. What we found was that two variables were significantly correlated with our proximal outcome of partnership synergy. Those were academic capacity, and that is, the community and academics believe that they had all of the skills that were needed to work in authentic partnership with community, and then also community capacity. What extent did the project felt, what extent did all of the partners feel that both the academic side and the community side had the skills and resources necessary to get her done or get the job done? And as you can see, those were associated with our proximal outcome of partnership synergy. Then now looking at the second dimension of our model, partnership dynamics, and in there we have things like structural dynamics, individual, academic, and community, capacity, relational dynamics, working with agencies outside the academic or community, like local public health departments, local educational programs and things like that. And then also, just the things particular to 501c3s or community-based organizations. As you can see there, the things that we identified both through the literature review and through a preliminary survey were formal agreements, power sharing, alignment with CBPR principles, power dynamics, flexibility and accountability, voice, language, and things like that. And two things that we found were very significant impacting our proximal outcome of partnership synergy were bridging social capital. And I love this. These are things like, does the community research team have the knowledge, skills, and competence to interact effectively with the academic partners? And then does the academic team have the skills and competence to interact effectively with the community research team? This is an interesting variable because it also actually has some to do with whether the academic partners actually hire community members to work within the university on the CBPR partnership. And that's not a little consideration. Partnership values, this was an assessment of whether both members of the partnership, the community and the academic partner, felt like they both agreed with the principles of CBPR as outlined by Israel et al., and also other key value elements. These people have enough shared values to be able to go forward and get work done. And then a little bit more about, I already talked about this, about the alignment with the CBPR principles, both the community-focused principles and the academic partnership or academic-focused principles. And as you can see, those were associated with our proximal outcome of partnership synergy at a 0.06, almost significant, but we felt like that was a significant relationship there. Another thing that we found was very significant in our overall composite outcome score that we don't want to show you any data about yet was something called partnership roles in research. And these were things like how much did the community partners get involved with different stages of the research project process, as you can see here. I think this wonderful measure was also developed by our colleagues at RAND in LA. And then another important variable that's associated with our composite outcome was resource and power sharing. And do both members, this was a measure of authenticity and power sharing. And we asked about, who hired personnel, how was the money divided, and how were in-kind resources allocated to the project from each side. These are what we are writing up for publication right now, and these are the most promising practices, those dimensions in our model that had multiple outcomes across this. We actually are looking at 7 outcomes in our model, as an earlier slide showed, and these particular variables at either the context or the relational or the research design and intervention level have a big impact on the authenticity of the CBPR partnership and the overall success of it. Those are the partnership capacity, alignment with principles, research tasks, influence, people feel like they're respected in the partnership, who takes leadership and who has the skills to take leadership, resource management, written agreements, control of resources, and bridging social capital. More to be published very soon. And Nina, I'm going to turn this back over to you.
Okay. So as part of the methodology that we used in this NARCH study, we had, as Bonnie so clearly articulated, 2 different surveys to the principal investigators and then to community partners around their perceptions of the partnering and their outcomes. Then we did also have, as one of the outcomes, a single health question, too, on whether they believe that the health status had improved as responsibility, as a part of their work as a partnership. So in addition to these other kinds of outcomes and the focus right now on partnership synergy, but on sustainability and other outcomes that were mentioned in the slide before. That was the quantitative arm of the study. We also had what we called the qualitative arm of the study to delve more deeply into the partnering practices and be able in some ways to get a perception of a more time sequence. What are the developments over time that partnerships need to go through to be able to implement the design, the research design, their interventions to make a difference, to have the outcomes that they're looking for. And we wanted to explore more deeply the different contexts of the partnering. So we were able to identify 7 case studies that were quite diverse across the country by region, by rural, urban, by ethnic minority status, and by other social identity. We had a project working with deaf population. We wanted to look at what makes a partnership successful, so we chose projects which were successful and had at least had a 3-year partnership. Most of them actually had quite a longer partnership with multiple grant cycles. And we were not looking at epidemiologic or other assessment studies, but we chose intervention or policy-directed studies. we went and visited the partnerships, we did focus groups, we observed meetings, we did interviews with folks, and we did a brief partnership survey. One of the tools that we used was called a historical timeline. We asked partnerships how they felt the community had influenced the start of their partnership, and when did their partnership start. And just with those kinds of questions, we can't show you these timelines right now because they haven't been published yet, and they actually belong to each of the partners. But they started back, like the partnership in the Bronx they got their initial funding in the late 90s from CDC, then moved to NIH funding, a faith-based partnership ending up in multiple areas of focus on health and well-being around food and diabetes, and also then around access to care, lack of access to care. But they started by talking about the burning of the Bronx in the 70s and participating in the civil rights movement. That's how they felt they started. A tribal partnership in the Northwest talked about what motivated them was the genocide committed by the Federal Army 100 years ago on a village. Each partnership had a different starting point that was not the date of receiving the money or of even getting together to start thinking about receiving the money, but it was when you just asked an open question of what's important to know about your community and how that influenced the start of your partnership, it really created a much stronger context understanding of what keeps partnerships motivated, what core values they share, what conditions are important for them, what informs their partnering practices. So we're writing individual partnered articles right now with a number of these case studies. And again, they vary from looking at colorectal cancer and screening in China, in a Chinese immigrant population, a environmental justice grant looking at in a Latino population, this faith-based grants, and we found that each context was so different, and it mattered to try and look at the timeline of how each partnership moved together to understand which practices became most important to shape which outcomes. And so the historical timeline that we built with them, we turned back to them, they gave us feedback on it. It became an important reflection tool for them. And some people, we've done this in exercises called River of Life exercise or a development of a timeline exercise, because all rivers have a beginning where they start from the mountains and come down, and and they all have tributaries coming in with what are the core influences that keep partners or collaboration working together. We also found in these qualitative studies a really deep breadth of outcomes, not just the grant outcome, whether it would be increased colorectal cancer screening or improved diabetes management outcomes or cardiovascular disease risk factor reduction, but had to do with building capacity of the communities, in building workforce capacity, building jobs, building deep sense of community that would grow out of promotoras working together. So this importance of going beyond just what we had identified before as metrics and measures that we could codify into instruments, that we could take validated instruments, we could create our own instruments, which we've subsequently validated. That was very useful, and the fact of being able to use qualitative approaches really strengthened both, I think, on the model, the deeper understanding of context and also of outcomes, and then how these processes actually interact with each other so that those grant research methodologies can be changed in that particular setting to produce a set of broad outcomes. So again, this is mostly focused on the quant side of our study, but just wanted to showcase that we also had this qualitative side and give one example of trust, which is always an issue in partnering or in community engagement. And our colleague Julie Lucero, we've just come out with an article in the Journal of Mixed Methods. It really looked at this issue from both quantitative and qualitative. We collaboratively together with many different focus groups and a new kind of typology with community partners that could look at critical reflective trust, where this is kind of all along the way people can work together over time, make mistakes, and still keep working together. And on the other side of it, having no trust or proxy mistrust. Many of us have entered partnerships on what we call proxy trust, where an individual invites you in because they trust you. But some partnerships or some community engagement might just be at a functional level. How are you going to work together? So this is not necessarily a Likert scale as much as trust typologies, which do have some dimensionality to them. But in her dissertation, which she wrote on this, she looked at both quantitatively, how did people assess their trust level from the beginning, and you can see on the left of the bar graph that, you know, it was kind of across the board, low level of trust, whether it was functional or proxy, and critical reflective, the purple bar is the lowest, and how they assess their trust in the end, or at the time where we asked the question, and in the quantitative instrument. And you can see that over the years, they have clearly articulated from all community partners and academics that the critical reflective trust was at a much higher level after working together. What she was able to do in the qualitative research is look at the developmental process of what matters most to strengthen and foster this change over time, and identified these kind of issues as communication ethics behaviors, whether they demonstrated commitment to each other, participation, a co-learning model. And those of us working in implementation science also very much try to understand the role of champions, of collaborative learning in appropriate settings. And so these kind of demonstration of commitment, as some people have just said, just showing up over and over again, not expecting community people to come to the university, but being out in the community, having a kind of participation that is actually authentic, Bonnie's been using that term, mattered in the qualitative data. So just to show that this has just been published in the Journal of Mixed Methods, this data right here. We also have been looking at what we've been calling cultural centeredness from our colleague Mohan Dutta, a health communication scholar, and trying to understand health issues of being centered in a community, not so much only whether there's an image on a curriculum that represents that community's supposed belief structure, but that there's a kind of a deeper knowledge of culture. And this is a billboard that I came across on the Navajo Nation. It's from the Department of Health, but have you noticed a change in your harmony, breath, energy? That would certainly not be a billboard you would see in New York City. It's very clearly based in a kind of deeper knowledge of how Navajos think about their wellness and health, and we tried to capture that as well. And we have other information or data. We're publishing an article right now on cultural centeredness from both a qual and quant perspective of measures that we've identified around cultural knowledge and values being within the research and how that then influences outcomes. So stage 3, we're going to end here, is this new grant to refine our measures. We're actually using all of our existing qual and quant data, looking at the literature again. What measures do we want to keep? Which ones are associated with outcomes? And how can we refine them to then develop, as a second half of the grant, an intervention for partnerships to strengthen the practices that they want to have. So we have what we are calling our Engage for Equity grant, just started at the end of last year, 5-year R01 funding. We'll be reconvening our national think tank of academic and community experts, and to help us all the way through. We've started that already. We're refining, as I said, and we'll be repilot testing our measures drawn from the previous survey that you heard about, translating them into Spanish as well, and doing psychometrics on the Spanish. We have colleagues in Puerto Rico who have agreed to work with us on this. We'll be doing internet surveys again next year starting, but looking at the reporter database, and hope to have at least 400 federally funded partnerships to refine our measures on, develop our associations with outcomes. And then we'll be conducting this comparative effectiveness trial with 40 partnerships, bringing them to Albuquerque for trainings, and then as compared to what we're calling the minimal intervention, which will be a web-based intervention. and we've been disseminating multiple publications, and I'm just going to end here with offering our contact information and giving a big shout out and thank you to all of our other investigators from UNM, University of Washington, Community Campus Partnerships for Health, the National Indian Child Welfare Association, colleagues at RAND, and colleagues at the University of Waikato and our think tank. So thank you very much, and I think we're now open for questions.
We are, and thank you, Nina and Bonnie, so much for your wonderful presentation. As was mentioned, we are now open for questions. As a quick reminder, you can submit those questions using the Q&A feature on the right-hand side of your screen. Please type your question in the provided field and hit submit, and we will be looking for those now.
Yeah, so absolutely encourage people, lots of folks on the line and a lot of great material to digest. While we're waiting to see things typed in, I just wanted to ask if you could say a little bit about one of the things that I think some investigators have struggled with is trying to understand the degree to which there's variation in how community-based participatory research methods are applied to different settings, to different stakeholders, to different research problems or questions that are being asked. I was wondering if you could amplify a little bit, just talk about, is there a range within this broader tent of CBPR? Do you see that there are some essential ingredients that need to be present in all cases? How can you help us think about the opportunities to use these different approaches in different studies?
Nina, do you want to address that? That's a really tough question, Boyd, because we don't want to be the community engagement police on one hand, but we also want to not have people appropriate a term that we think is about, authentic participation with a social justice perspective. Nina, do you want to say more?
Yeah, I do think it's exactly, you portrayed it exactly correctly. There's this tension of not wanting to say there's not one way of doing this. We found that there is tremendous variation across the country. There's a growing variation as well with folks who might not yet be at the partnership stage but are exploring community engagement. They're reaching out to people. They're saying, how can we work together, new contacts with new community organizations or new contacts in a community, setting. So the challenge is for people to be honest and to name what they're doing. And if they're really only doing unidirectional, let's present our information to you, community members, to listen to on a community outreach basis, that to me is not really even engagement. That's just us telling them what we might have heard or know or our results or whatever. So I think at a minimum there has to be some set of principles of engagement, of bidirectionality, and of mutually adopting a co-learning approach. Whether you're at a complete partnered stage or not, I'm not sure that has to fit within the, I think the tent is bigger than that, but I don't think it is unidirectional. So I do think there's a set of principles. We do go back to our core values in our measurement instrument and the principles as developed by Israel et al. Colleagues to kind of say, what are the starting points? What are those sets of principles that need to be aligned to work together? And again, we encourage, and I know Barbara does this as well, encourage each community-engaged effort to identify and create their own set of principles. They don't have to adopt a set of existing principles and not transform those, but to have these principles of how they're going to work together, how they're going to make decisions, how they're going to involve different people at different times. Because again, academics have a different set of skills and community members have a different set of skills. You don't all have to have the same set of skills. But I think one last thing, I do think CBPR came out of a public health social justice agenda, and I think it's important to, if we really want to address health inequities, that's still key. Though community engagement can be very helpful and useful at a broader, but again, a set of core principles that are shared is key. And there's an increasing set of stakeholders, too, in terms of PCORI, patient stakeholders, precision medicine, in terms of family stakeholders that are growing. And I think we have to figure out how they can be not manipulated or used just for our academic or clinical purposes, but really receive the benefit as authentically as possible.
Yeah,
Great.
so I'd like to add that not only receive the benefit, but define what the benefit is, and also to ask our community partners, why do you think this problem is this way? I mean, theories of etiology coming from the community, and also, you know, best ideas about what has worked in the community for interventions, you know, culture-centered interventions that have really grown up out of the community suffering from these health disparities themselves. To me, that's those are a few elements of really authentic community-based participatory research.
Wonderful. Thank you so much. And I can now see that a number of questions are flowing in, so let's get to those. The first one from Perry Foley says, you mentioned CBPR roles specifically funded from members of the community of focus at a component of partnership dynamics. Would you be able to expand at all on a few of the roles? It looks like, yeah, roles of the community. You probably see the question as well?
Sure. Nina, I can address that, or do you want to?
Oh, go ahead. Go ahead.
Well, I actually just last Friday finished data collection on a psychiatric epidemiology study in 22 tribal communities. And, you know, what's wonderful working with tribal communities is if you don't have authentic participation and you try to go into the res, they will have the tribal police escort you off the res. And let me tell you, that has happened. So certain things, that the way that I worked with my tribal college partners were, they were very much interested in strength-based resiliency approaches to wellness, and they wanted to make sure that we collected as much data on that as we could in order to really show that people who had been able to reinstitute cultural norms about appropriate behavior within families or within social institutions like school or, you know, among towns on the tribe, that you know, those things that had been actually eradicated by cultural genocide, that, you know, they were the ones that told me what the theories were about why there were so many health disparities, and they were the ones that told me what data they wanted to collect. So, and they also told me how to do the sampling. So that was a huge benefit to the science itself, because they had a much deeper sense of what some of the etiologies of these problems were than I could have ever had sitting here and universalizing my subjectivity from Seattle.
And just to add to that, and Bonnie showed it earlier, the partnership involvement in research steps, it's the CERI Index, Community Engaged Research Index, that actually our colleagues at UCLA created, and we're expanding a little right now for our new study. But it talks about at each stage of the research, whether it's in designing the problem or conceptualizing the challenges or resiliency issues that Bonnie's talking about in the conceptual stage, or whether it's deciding and working with creating the background literature, deciding research methods, the sample. In data collection is often a time when a lot of researchers benefit from having community members in their advisory boards work with them, but that's by itself is a very limited role, but it's certainly data collection. And then the most important, or as important to me, is involving community. They may not be able to do the SPSS or SAS or whatever other analysis package you're using, but they certainly are critical in understanding and interpreting the data and its relevance for changing practices, programs, and policies in the community. So data interpretation is a key step, a key stage for re-engaging community partners who might not be doing the statistical or qualitative data analysis piece as in the more analytic time, but the interpretation becomes key for dissemination.
Great, thanks. So the next question was asking about specific either a citation or materials that you could recommend for some of the exercises you mentioned. There's a specific mention of the E.G. River exercise. Any places to point people? And then, of course, we can follow up and post the resources on, as part of the archive. But just wanted to know anything to share.
The River of Life exercises, well, I mean, there are many popular education texts out, Training for Transformation being one of the best coming out of Africa. But I mean, I have on my own website, the Center for Participatory Research website at University of New Mexico, there's a curriculum tab, and if you go, there's an empowerment curriculum under that, which has a lot of it was co-created with colleagues from Latin America in Spanish, Portuguese, and in English, but it has a lot of these exercises in it for how you engage and facilitate with communities. Maybe what I'll try and do after this is actually highlight the River of Life and actually put it up in a way that's more usable and send it to you, David, for a link, because
Perfect.
There are some wonderful exercises that enable communities to create visions together, to create history together, to create kind of practice together, and those don't come out of a research angle as much as a popular education angle and learnings from Paulo Freire's methodologies. So I could send you some references as well, David.
Oh, that would be terrific. And then, of course, we can distribute those further. So next question about IRB challenges. So the question reads, what IRB challenges have either of you or both of you experienced with CBPR research, and are there resources to help investigators navigate IRB review and approval?
That's huge. In the research project that, in the epidemiology survey that we just closed out a collection from, I would say that 50% of all of our FTE was used actually getting IRB approval at the UW level and also at the community level. So it's a big deal. But, given the history that, research was used as a tool of colonization, and it makes sense that people need to feel like that their voices and that their review is not cursory. They need to feel like it is absolutely part of the approval process. So that's just right now, I think, what it's going to take in some instances to have that much FTE around approvals.
And another component of it is that, in fact, communities, just as Bonnie, it isn't just tribal communities that are now expecting or have IRBs, but community IRBs and research review boards are growing as well for researchers who may be working in other communities. So it's a phenomena that's it's a important understanding of our responsibility, accountability to communities. The other part of IRB, just for me, is my IRB that I work with here, they know me now, but I put in a more initial IRB saying we are going to be creating we have a think tank or community advisory board or tribal research team. We'll be co-developing our instruments, and after they are co-developed, I will be returning to the IRB with an amendment. Or we will be pilot testing our instruments, and after they've been co-developed and pilot tested. So I tend to know that I have to go through multiple amendments if I'm going to work collaboratively with the Community Advisory Board to develop instruments or pilot test them or develop interventions and then pilot test the instruments, the evaluation tools, whatever they are. So it means that you have a more ongoing relationship with IRB over time if you're going to do a CBPR project or a community engaged research project. And there's certainly the Campus Community Partnerships for Health website has they're very interested in research ethics, and there's a research ethics page, and they might have more tips, but I would just say recognize more that it is a part of the research, and we all know that, but it becomes more an iterative part of a research for community engaged research.
Yeah, and, in some cases, tribal IRBs will tell you what is going to work in your research and what's not going to work in your research. It's surprising how much excellent, you know, implementations research data that you can get from local boards like that. I mean, I think that they can be, at least in tribal communities, maybe in other communities as well, excellent sources of implementations research information.
Great, thank you. So final question. Cheryl Merzel would be very interested in hearing your thoughts on balancing fidelity to an intervention with community participation control as a program unfolds.
Well, I'm actually working with that right now. I've got another R01 trying to implement a alcohol harm reduction intervention at tribal colleges, another one, and we definitely are having implementation issues, but you know, it's all good. It's all excellent data about why something that is most useful in mainstream colleges or in other contexts would or would not be useful adapted to a different context. And let me just say this is that, you know, I actually just finished up a wonderful stint on the Council of the National Institute of Child Health and Human Development, and it's not just for implementations research, but all of sciences trying to understand reproducibility, that, you know, even within the same context of time A to time B, that you might not get the same results, you know, whether, you know, fidelity is strong or not. So I think that that's one of a bigger issue, you know, within science itself about how we hold the truth of one particular research finding over time in a different context.
So I agree. Oh, were you finished, Bonnie?
Yes, yes.
So I agree that this is a key issue, and we're in a process of an R01 here with 3 different tribes and trying to implement a intergenerational family prevention program with 4th and 5th graders, parents, and elders. And we co-created this curriculum and program with the 3 communities, both together and separately at the same time, by taking from another wonderful evidence-based program up working with the Anishinaabe tribes up in the mid-north of the country. But by redesigning, recreating it, we tried to honor this one, which I find very helpful, Penelope Hawes' way of thinking about intervention fidelity, where she talks about we need to start focusing more on the function of fidelity, not the form of fidelity. So if the function is to attain and have a place in the curriculum where community kids and elders and parents can talk about the vision that they hope to see for a healthy community 10 years from now, that function will be across all of our 3 communities, but how the community tribal research teams implement that, the form it might take may be different. We have an agreement that we have an aggregated data collection instrument. We are working together as an intertribal collective to learn from each other, but we recognize that the curriculum is trying to retain certain evidence-based functions all the way across, even with changes and continual fluctuating changes over time in the implementation because they're being responsive to their community families. But the functions that we've established as kind of higher meta parts of the intervention seem to be maintained. And so we have a 12 session curriculum that's done at dinner time, and we have traditional foods, and we've incorporated a lot of wonderful kind of strengthening culture and language into these curricula, but they're not exactly cookie cutter the same, even though we're sharing a lot. And I think that's an important change in understanding on intervention research these days, that we shouldn't be looking for cookie cutter anymore. We should be looking for responsiveness to settings and communities and identifying the priorities of those communities as central, so that, to me, what's most important is that sustainability lasts after the money ends and grant funding ends and communities are left. And so how do you work towards a sustainable approach? It has to be then recentered into each community. So I think intervention science has to challenge itself these days, and so hopefully Penny Hawes' way of thinking about it is helpful.
Thank you so much, Nina and Bonnie, and also thank you to David for his time this afternoon. I wanted to be cognizant of the time and go ahead and wrap up, so I want to let you know that your feedback is important to us, and we encourage you to complete our online evaluation, a link to which will be sent to you in an email shortly. Finally, as mentioned, we would like to continue this discussion from the webinar online at researchtoreality.cancer.gov, where you can engage the speakers and other participants through discussion forums and posts. Our next Advanced Topics webinar will be March 31st, and we look forward to seeing you there. Thank you very much, and you may disconnect at this time.